So, dear colleagues, it is a great pleasure for me to share this first lecture on one of my favorite topics, namely regenerative periodontal therapy, focusing on intrabony and furcation defects. And I will try to make a compilation of our evidence-based approach that we have elaborated on in the last 2 decades during my stay in different countries, now finally in Switzerland since more than 12 years. And I would like to give you some concepts on how you can treat your patients and how to obtain successful results. So in fact, I will elaborate with you on the rationale for performing regenerative approaches. Then I would like to point out our goals and also to make a compilation related to the materials that we may use and the materials that have been shown to promote true periodontal regeneration. Of course, some of the factors are very important because they will influence our results no matter what kind of materials we're going to use. And I would like to provide you with some guidelines on how we can treat successfully different type of defects. So, dear colleagues, what is the rationale to perform a so-called reconstructive periodontal therapy? And let me start with the angular or intrabony defect, because these defects are very frequent in our daily practice. And all of you know this type of bone loss, both vertically and horizontally. And if this bone and attachment loss is very advanced, then it may reach the apex of the tooth, and at the very end, it can cause tooth loss. So if you go to the literature, we have some key papers that have looked at the fate of the teeth that have been associated with an angular bony defect. And if you look at this publication, they have categorized the defects into 3 different groups based on the intrabony component that was measured on the X-ray. Class 1 or degree 1, it was an intrabony component of 2 millimeters. Class 2 was an intrabony component between 2.5 and 4 millimeters. And degree 3 was an intrabony component deeper than 4.5 millimeters. And these patients did not receive any periodontal therapy. After 10 years, about 70% of the teeth that were associated with an intrabony component deeper than 4.5 millimeters were not any longer in the oral cavity, indicating that they were extracted or they were not any longer suitable to ensure sufficient chewing function. In conclusion, we need to treat these kind of defects, otherwise we increase the risk for further bone loss and finally tooth loss. The second defect type that is very complex and not always easy to treat is the furcation involvement. And what does it mean? It is a defect in the interradicular area of multi-rooted teeth. And we all know these kind of defects. You see here a molar that has a horizontal and a vertical bone loss, not only difficult to access but also difficult to clean during surgery and of course during the oral habits, the daily oral habits of the patient. Even if we would raise a flap, it is quite difficult to access, and we all know this problem from the daily practice. Histologically, such an area is characterized by a biofilm colonization of the furcation area, and of course an ingrowth of soft tissue, of so-called granulation tissue into the defect that encompasses also a heavy infection with bacteria, and it is very difficult to access and to clean. So if you go to the literature and we look at some long-term studies, I just listed some of them, some classical studies with a follow-up of at least 10 or 20 years, the first teeth that are usually extracted are the molars. Why? Because we have a very difficult anatomical situation, and these molars can be very difficultly kept stable. So what is now our rationale for a regenerative therapy? First of all, from a clinical point of view, what I would like to obtain is to reduce the depth of the pocket. In other words, I would like to have a probing depth reduction, but without cutting the tissue away. I would like to have a shallow site, a probing depth of about 3-4 millimeters. In some cases, we may even accept 5, but without cutting the tissue away. But I would like to build up the tissue that would support the tooth, and in the same time would also enable a shallow probing depth by gaining so-called clinical attachment. So by eliminating the intrabony or the angular defect, we would facilitate the biofilm control. In other words, for the patient, for the dental hygienist, it is easier to clean, to maintain this area, but also to gain more support for the tooth. And what is our final goal? To maintain the dentition lifelong. In other words, I would like to improve tooth prognosis. So if I would go to my goals from a clinical point of view, keep in mind, first of all, a shallow site, probing depth of about 5 millimeters maximum. Of course, I would like to have always 3 millimeters, but it is not always the clinical reality. No bleeding, this is very important. No bleeding, no suppuration. In other words, an inflammation-free area. If possible, complete closure or regeneration of the intrabony component, and the same also in a furcation involvement. So look at this case. This case I treated about, I think, 22, 23 years ago. You can see these two incisors in the mandibular anterior area with a bone loss reaching almost the apex of the lateral incisor. And after 9 years following my treatment, the teeth are still in place. They can even support a bridge. And you can see a feel of the intrabony component, stability of the results. Another case, this patient was referred to me in 1997, and you can observe the clinical problem, a probing pocket depth of about 12 millimeters distally to this upper canine. And if you look at the X-ray, you can see that we have a huge bone loss, both vertically and horizontally. So if the patient would lose the tooth, of course we can replace it with a fixed prosthetic reconstruction, but at the very end, we will end up in a huge defect that is very difficult to reconstruct, very difficult to place an implant that should look like a tooth at the very end. And at the very end, we need to do our best to improve the prognosis and to maintain the tooth. Look at the clinical situation during surgery. I opened the flap. Luckily, it was a molar, which means that I have to deal with a long root, and for this reason, the tooth was stable. I performed the regenerative approach using an MR matrix derivative, and at the re-entry, after 4 years, because this was in the frame of a study, I opened up the flap again, and what you can see here is nothing else but an almost 100% regenerated Intrabony component, still a shallow Intrabony component of about 0.5 millimeters is visible, but we gained about 4 to 5 millimeters bone and support for this tooth. In other words, I managed to improve tooth prognosis. What about class 2 furcations? Have a look at this case. It's a lower jaw mandibular furcation defect. And we know from the literature that such a defect is not easy to regenerate, and such a molar is not so easy to keep on a long-term basis. So the probe almost passes completely under the furcation. It's a class 2, it is not a class 3. In this particular case, I performed a regenerative approach, including the use of a bone graft and a membrane. And please observe the outcome after 5 years, indicating an almost complete closure, radiologic closure of the defect. And in other words, a class 2 furcation became converted into a class 1 furcation defect, which is much more easier to be cleaned by the patient. So I think that it's important to go a little bit into the biology and to look at the histologic types of healing. So first of all, in most cases, when we perform a non-surgical treatment, subgingival scaling and replaning, curettage, flap approach, we open up, we clean, we close the flap. We are facing a so-called reparative type of healing. We may end up in a shallow pocket if you cut the pocket away, but the healing is characterized by a so-called long junctional epithelium in most cases. And this you can observe very nicely on this histological image on the right that depicts the surface of the root and the proliferation of the epithelial cells. You see these dark brown staining epithelial cells that migrate from the coronal part into the apical direction, very often reaching the bottom of the pocket. And please observe we have some regeneration of the bone that you can see here. It is not stained, but between the bone and the tooth surface, what we can see is this epithelial layer interposed, indicating that we do not have a newly formed periodontal ligament, and we do not have a connection between the root surface and the bone. So what do we understand when we use the term periodontal regeneration? Because this is very important. Many people, many colleagues are using the term regeneration based on an X-ray. But if I analyze an X-ray, I cannot make any statement about the quality of the tissue. The quality of the tissue can only be analyzed and can only be demonstrated via histological analysis. So, if you look at this slide to the right, what you can observe is the right root. Please observe a notch in the root surface, this hole. This notch is always placed during the experimental procedure. So you open up a flap, you face an intrabony defect, you clean the defect, you remove the granulation tissue, and you want to know where the most apical part of the defect is. You take a burr, you make a small hole in the root surface. This is a so-called notch. It's the reference point for your measurements, because you know that the bacteria and the plaque was invading that area. So all the tissue that forms coronally to that notch is newly formed periodontal tissue. So coronally to the notch, what you can observe is this dark green line indicating a newly formed cementum. You can see newly formed periodontal ligament connected to the newly formed bone. This is the green stained tissue, and the proliferation of the epithelial cells stops at the most coronal part of the newly formed cementum. So this is, dear colleagues, the only possibility to prove, at least nowadays, periodontal regeneration. And now we are facing a very important problem from a biological and of course from a clinical point of view, because we have a tremendous variety of different materials, starting with biologics, with membranes, with bone grafting materials, combinations thereof, etc. And if I'm critical, I have to ask myself, what kind of material should I use? Which material may promote periodontal regeneration? What should I expect as a clinician from a material that I use in my patient? So first of all, dear colleagues, the material needs to have a biologic activity, otherwise it's worthless. So first of all, the material has to have a positive effect on promoting proliferation and migration of the cells, and namely of the most important cells for periodontal regeneration, and these cells are the cells from the intact part of the periodontal ligament. Okay, we need periodontal ligament in order to accomplish periodontal regeneration. Second important objective is to exclude epithelial proliferation from the wound. In other words, the material that you use should prevent or slow down at least the ingrowth of epithelium into the wound and of the gingival connective tissue that is located at the inner part of the flap. This is very important. And of course, if you are facing a very large defect, what do we need? We need space, because if you don't have space, you cannot regenerate. It's very simple. So in other words, you need a material that has sufficient mechanical stability in order to enhance the space provision and to promote wound healing. Okay, we need to facilitate and to ensure wound stability. So if we go now to our literature, we have a plethora of materials. Look at the big group of grafting materials. I will come back to this topic a little bit later. So we have grafting materials. We have the so-called guided tissue regeneration principle, that is the use of barrier membranes, either bioresorbable or the older generation that was non-bioresorbable. Then we have the enamel matrix protein derivatives, EMD. Then we have a variety of growth and differentiation factors that we can use. PDGF, this is platelet-derived growth factor. BMPs that have been tested for periodontal regeneration as well, BMP2, BMP7. they are not routinely used. Then we have one material called FGF2. This is fibroblast growth factor and is used for periodontal regeneration, mainly in Japan. We have the GDF5. This is growth and differentiation factor number 5. That has been also tested and used a certain time at least. And then we have the platelet-rich plasma. That was the first generation of platelet derivate. And we have nowadays the platelet-rich fibrin, or PRF, in different formulations. We have a huge story about this. We have different formulation, different centrifugations, etc., etc. And then, of course, there are also different combinations. Grafting material with a biologic, for example, grafting material with an emmetmatics derivative, or grafting material and the membrane, or maybe PRF and using a grafting material, etc. So let me go over the different materials. And let me elaborate together with you which materials may promote periodontal regeneration from a histological point of view in humans. And this is a systematic review where we looked at the entire available materials based on human histologic evidence. And the conclusion of this study is a huge study. You can write me an email. I can send you this paper. It's a very large paper. We measured and extracted the data from every single study available in the whole history of periodontology based on human histologic material. And at the very end, we concluded that there's very limited evidence suggesting that bone grafts, bone biomaterials may promote periodontal regeneration. So in fact, if you take a grafting material, you put it in a pocket as you do it with a filling, with an amalgam filling or composite, you should not wait for periodontal regeneration. You should not expect that. Usually, we may see a fill of the defect, but it is not a new periodontal regeneration. So it is usually a space filling. However, we still may use bone grafts in periodontal defects. But the reason is not to obtain regeneration coming from the graft itself, but the graft is in fact stabilizing the flap, stabilizing the blood clot, maybe via the porosity, or is a carrier for growth factors, okay, or some other biologic active molecules. In other words, we still may use a graft, but keep in mind that the graft itself is rather carrier and stabilizes the wound, and itself it doesn't promote regeneration. However, when we select a graft or a bone biomaterial, our selection process should be based always on a biologic rationale and on a solid histologic evidence. In other words, I would never use a material in my patient that has not been shown to have a positive activity in animal studies, in cell cultures, and finally also in human histologic proofs. That's very important. So be careful, be always very critical when you use your materials. So let me make a short summary about the materials that have been shown to promote regeneration in humans. Grafting materials, limited types. The best one, the gold standard still now, is the own bone, autogenous bone, okay? Either intraoral or extraoral, usually intraoral bone. Human material, that means allograft, this is a material that originates from the same species. and certain types of xenogenic materials. That means materials that are originating from other species, okay? Of course, we have the membranes, guided tissue regeneration. And guided tissue regeneration has been demonstrated to promote periodontal regeneration, okay, in humans. No matter what kind of membrane you use, the principle is always the same. It may promote regeneration if you don't have a complication. In enzymatic proteins, like endogain is the material that we have. Then we have recombinant platelet-derived growth factor, PDGF. It is the so-called GEM21. It's not available in Europe, but we have it in the United States, combined with a graft, and combinations between a graft and the membrane, or EMD and the graft. Don't forget that if we look now at synthetic materials, so-called alloplastic materials, we do not predictably expect periodontal regeneration. Usually, these particles are encapsulated in soft tissue. So be careful, please, when you use synthetic materials, because when you use them alone without combining them with a membrane whatsoever or a biologic material, they will not work usually. Look at some examples. This is one study that we published many years ago, but the biology is still the same. We tried to use a beta tricalcium phosphate. So what we did is to open up the flap, remove the granulation tissue from the defect, fill the defect with the graft. You can see in this slide to the right, at the bottom, at the corner, the particles in the defect. And if you are not careful and you only rely on your radiographic evidence or image, you would term this healing type periodontal regeneration. But if you analyze now histologically this area, this is not regeneration, dear colleagues. This is in fact a healing characterized by a reparative type of tissue, and this is evidenced by a lung junction epithelium that proliferated from coronally, you can see it on the slide, to apically, almost until the most apical part of the defect. We have some particles that are surrounded by soft tissue, no connection with the bone. However, you see these particles in your X-ray, okay? So these particles are visible in the X-ray, and if you are not careful, you would interpret these particles as periodontal regeneration, but it is not. In other words, this material that we tested in this study doesn't have any biologic activity, okay? It's a filler. Let me elaborate a little bit on the biologic background of guided tissue regeneration, because I think this was a very smart idea. It is not a new idea, but it was the first biologically driven treatment approach in periodontology. So by means of a barrier membrane, we have an exclusion of the epithelial cells and of the connective tissue cells that are at the inner part of the flap, okay? So in other words, in a number of studies, it was demonstrated that the cells responsible for periodontal regeneration are located in the intact part of the periodontal ligament, in the apical part of the defect. And if we are able to isolate these cells by a membrane, they are going to repopulate the defect, the root surface again, creating a new layer of cementum, a new layer of periodontal ligament. And if you look at the bone, from the bone we also have bone cells that will also repopulate the area. And this will lead to periodontal regeneration. What is the other important function of the membrane will enhance wound stability. Okay, this is very important. So if we use, for example, a very soft membrane and we don't have a support for this soft membrane, what is happening? The membrane is collapsing in a defect. Okay, very simple. So we don't have the chance to have a huge amount of regenerative tissue. So if we are successful with the GTR procedure, in other words, if you don't have a complication such as membrane exposure, invasion with bacteria, infection, what we obtain, and we demonstrated this, you see, many years ago. This publication was in 99, so 22 years ago. We have the root surface, and on this root surface, we obtain the following. You see this dark layer of cementum. This is the dark green layer, periodontal ligament and bone. And if I magnify this area and I look at this at a high magnification, what I can see is cementum, periodontal ligament and bone on this root surface, on this defect, indicating true periodontal regeneration. Then we have another very interesting material or group, or like a protein shake, protein cocktail, okay? It is not one single protein, are the enamel matrix proteins. And these proteins have been shown already in the 90s. The first publication resulted in 97, that these proteins, once applied on the root surface, will attract the periodontal ligament cells, and these periodontal ligament cells will repopulate the root surfaces. In other words, by using enamel matrix proteins, we promote periodontal regeneration in humans. However, technically, this is not an easy procedure. It is less complicated than using a membrane, but it is still complex because we have to be very careful on how we prepare the flap, that we don't have a blood contamination on the root surface, and we have a very nicely secluded space, a primary closure. One problem that may be associated with enamel matrix proteins is the fact that in very large defects, and these large defects are called non-contained type defects, the flap may collapse into the defect and may limit the available space for the regeneration process. Look at this example. We published already 22 years ago some data evaluating the potential of enamel matrix proteins on periodontal wound healing and regeneration. And this is, for example, a human biopsy where we demonstrated periodontal regeneration. You can see it here from the apical notch to the coronal notch, and the apical notch is the most apical part of the defect. The coronal notch indicates the level of the bone crest. What we had here is in fact newly formed cementum. You see this light layer deposited on the dark reddish layer of old cementum, periodontal ligament and bone, and these three structures are together, are an entity. If you look more coronally, what you can observe is in fact a proliferation of the epithelium, but the epithelial proliferation stops at the most coronal part of the newly formed cementum. If I magnify this area from the box and I look at the right at this higher magnification, what you can see is in fact the newly formed cementum very well deposited on the old cementum on the root surface, a new periodontal ligament, and a new bone. Okay? Indicating a true periodontal regeneration. So what can we expect when we use this treatment? Look at some studies. One paper from our group, I started to work with this material already in 1996. I was one of the first clinicians that have tried enemiomatics proteins in periodontal regeneration. So in 2008, we published 10-year data on this. 12 years ago, we published 10-year data, imagine. So look at this case. This young lady, she had an aggressive periodontitis, very deep defects in the lower jaw area. So many clinicians would solve this problem with an extraction and place an implant or a bridge or whatsoever. I open up, clean the defect, place enemiomatics proteins, close the flap. You need to stabilize the teeth if they are a little bit mobile. I would advise you to stabilize it with an orthodontic wire nowadays because it doesn't break. 10 years later, you can see 10 years later, of course it's not a perfect result, but the teeth were almost in the air. 10 years later, we have stable situation. We have even an slightly increased width of attached gingiva. And you can clearly see that we have here a stable and non-inflamed situation, indicated also by the X-rays. We have a regrowth of bone, and the probing depth is about 3 millimeters here, maximum 4, indicating that we improved the prognosis of these teeth. So, in conclusion, if I elaborate on the biology of periodontal wound healing and regeneration, again, please aware that changes in clinical and radiographic parameters, such as, for example, reduction in probing depth, gain in clinical attachment level, or a so-called radiographic bone fill, doesn't necessarily imply periodontal regeneration. For this, we need first biologic background, we need human histology or animal histology at least. What about the role of the defect morphology? It's very important. We have different types of defects. We have so-called contained type defects, so-called 3-wall defects. We can have 1-wall defects. And we all know that the more walls a defect has, the better the healing will be. So look at these studies. So if we have, for example, studies where an intrabony defect was treated either with emdogain or a membrane, EMD is emdogain, and they are compared in so-called contained type defects, 3 or 2-wall defects, the results are very similar. You see the clinical attachment level gain about 3 millimeters, sometimes 4, sometimes 5, but not big difference between the two. However, look at the last line. If we look at the same materials, but the defect anatomy is different, in other words, we use these materials in a so-called 1-wall or non-contained defect, then using a titanium reinforced membrane yielded better outcomes than using a fluid material like EMD. You see 4.1 millimeters versus 2.4 millimeters. And in this study that we performed, the only difference was the defect anatomy. I will elaborate on this study a little bit later. So don't forget that for periodontal wound healing and regeneration, what is important, it is to ensure at least for 2 to 3 weeks a stable wound. No infection, no wound collapse or flap collapse into a defect, and stability of the blood clot. That's why we need to do our utmost in order to improve this first phase of healing. What is going to happen if we have a collapse of the flap? Look at this slide to the right. In fact, the flap is collapsing to the root if you cannot maintain it, and we don't have any regeneration. We have a long junction epithelium up to the most apical part of the defect. Okay, let me come back to the study that I mentioned before. In this study, we only included non-contact type defects. You see this one wall defect. So in this case, we used only EMD. So we opened up, cleaned the defect, placed EMD on the root surface, closed the flap. The healing is not so bad. We have a slight increase in soft tissue recession and also fill up the defect in the intrabony component of the defect. Second group was treated in the same way from a surgical access point of view, but instead of using a fluid material, we used a so-called titanium reinforced membrane. Okay, of course, this is more challenging to use. On the other hand, the titanium reinforced membrane can support the soft tissue, will prevent a collapse of the flap and the soft tissue into the defect. Okay, you can see that the defect looks very nice. We have less soft tissue recession. And if you look now at the measurements that we had, look at the upper table, especially if you look now at the probing depth between the two groups at baseline, it was no difference. And if you look now the change at 1 year, the GTR group performed much better compared to the EMD group. If you look now at the clinical attachment level, we see that the gain, the change, amounted to 2.4 millimeters in the EMD group because we had more collapse of the flap, and 4.1 millimeter in the titanium reinforced group. Okay, so almost double the value. If you look now at the so-called frequency distribution of residual defects and clinical attachment gain in the test and in the control group, because this is very important, this means how many defects gained a certain millimeter, a certain value. You see that if you look at the gain of 4, 5, and 6 millimeters, the GTR group gained 4 to 5 millimeters in about 71% of the cases, more than 6 millimeters in 8% of the cases. If you look now at the outcomes obtained with EMD, then the majority of the cases improved to 2 to 3 millimeters, about 67% of the cases, and some cases gained almost nothing. So this indicates that if we are able to stabilize the blood clot, the wound, we may be more successful. Okay, but keep in mind the factors that influence the healing. Which are those? Oral hygiene, very important. I would never perform such a surgical procedure in a patient that doesn't have a plaque control below 20-25%. Okay, so select please the case, select please the tooth. Then of course the gingival phenotype is very important. In thin tissue is more difficult to work than in a thicker tissue. The presence of a gingival recession, and of course if I have an exposure of the membrane, this may be very negative. And smokers, okay, heavy smokers react significantly worse and unpredictable compared to patients that smoke less than 5 cigarettes a day over many years, or non-smokers. Defect size. If I have a very wide defect, as you can see it in this location, very difficult. So in other words, if I have a narrow defect heals much better than a wide defect, because in a narrow defect it is much more easier to stabilize a blood clot compared to a wide defect. So don't forget that we have a significant influence of the flap design and of the surgical technique on the clinical outcomes. That's why nowadays What we aim at is to preserve the integrity of the interdental soft tissues by using different types of flap approaches. And the first that has looked at this was Takai. In 1985, he described a classical papilla preservation technique with an incision coming from palatally. This technique was later modified by Kevin Murphy. And then we have the so-called facial incision. This is the modified papilla preservation technique, or the more simplified version where we cut a little bit obliquely. I will show you some videos a little bit later on that. This is dependent on the availability of the interdental space. And we have also a very smart technique by Dr. Trombelli, where they use the single buccal flap. Okay, of course, it can be also single palatal flap. This means that I would open only one side of the flap or of the defect, whereas the other side stays stable. I clean the defect, I don't move the papilla, and I just replace the flap and close it. So this is the single buccal flap. You open buccally. Of course, you cannot do it in every single case, but you can open the flap buccally, you clean the defect, you perform the scaling and root planing, insert the regenerative material. In this case, it is not possible to use a membrane, because for this, I would need to open also lingually. And then you place the regenerative material, either alone or combined with the graft, and close. Very simple. And then if you look at the healing, this will improve the outcomes, because we don't open completely and the interdental tissue integrity is ensured. So look at this very nice systematic review performed by Professor Graziani in Italy. He looked at the outcomes following flap debridement alone without any regenerative material, and he looked at the performance of different types of flaps. Look at the open flap debridement or the classical modified Widman flap. You just open up, clean, and replace the graft, or maybe they use also some paramarginal incisions. If you use the flap design in a classical way, then the gain of clinical attachment is about 1.25. Okay? If we are able to maintain the interdental papilla, and we use the so-called modified papilla preservation technique, or the simplified papilla preservation technique, the attachment gain is of about 2.5 millimeters. The mean attachment gain is more than 1 millimeter above that what we can obtain with an older type of flap design. What is the take-home message from this? Please try to keep the papilla intact, okay? Whenever you can. Very simple conclusion. So the flap design, of course, is a matter of the defect type and of the defect location, but always focus on preservation of the papilla, okay? Look at this case. Very, very difficult to treat case. In this particular case, we have an attachment loss reaching almost the apex. And this bridge was vital for the patient. If he would lose the tooth, he is losing the entire prosthetic reconstruction in the mandibular frontal area. So what I did here, I opened up, cleaned the defect, and you see that I can reach almost the apex. Luckily, this was a contained 3-wall defect. So what I do here, I use the MD, kinematics derivative, and I waited 5 years. Look at the regrowth of the bone. Very, very impressive. Okay? So we have here an improvement from about 40 millimeters probing depth to about 4 or 5 millimeters probing depth. 9-10 millimeters of clinical attachment gain. Very impressive result. Look at this case. This is a lady that was referred to me with this periodontal problem. So she had in the upper lateral incisor area a probing depth of about 40 millimeters. The probe is reaching the apex almost. And if you look now at the defect on the X-ray, you can observe immediately that it is a very complex situation. So we are facing a kind of bridge, a bony bridge mesially, a huge defect distally. Imagine if this patient with a rather thin phenotype would lose the tooth, we have a huge problem. To place here an implant is not so easy, because the implant should look like a tooth, not like a screw at the very end. So this is important. In these cases, I do my best to save the tooth for the patient. So what I did, I opened up, and I think that we can all agree that this is not an easy periodontal case. Of course, we have to make sure that the tooth is vital. It was vital. It was not an endoperio problem. And what I did here is to use enemematrix proteins, stabilize with my sutures the wound, and achieve the primary closure. Of course, I would take into account a small increase in recession. However, the outcome is very nice. I have now maybe about 4 or 3 millimeters of probing depth, no bleeding on probing, and a stable clinical situation. Look at the outcome from a radiographic point of view. At 3 years, I have a almost complete regeneration or refill of the intrabony component. No bone graft was placed here, and I was able to save the tooth for the patient. Now it's about 6 years ago. The patient has still the tooth, very happy. Maybe the recession could be corrected, but she is happy with the final outcome. What about the influence of the biomaterial on the clinical result? A very nice study by Leonardo Trombelli, published in 2002, is just to give you one idea. If you don't perform a papilla preservation flap, if you are not able to preserve the interdental papilla, then look at this gain in clinical attachment level based on the material. Sometimes is even below that what we can achieve with a flap approach, minus 1.5 millimeters to 1.4 millimeters. Okay? So in other words, you can use the best biomaterial in the world. If you do a lousy surgery, you can forget about that. Very simple conclusion. And here you can see the different values that they have calculated. Of course, the autogenous bone in this study performed the best. Also some other biologic materials, but if you look at some lousy materials, like for example polylactic acid granules that are biologically not funded, we have defect deterioration, resorption of the bone of about 1.5 millimeters. In other words, 1.5 millimeters worse than doing nothing, just opening the flap. So that's why select the right material, but also select the right flap design and perform the right surgery. So let me go over to our treatment strategy, first of all in intrabony defects. This is an important consensus conference report that we attended some years ago, and the results were published in Journal of Periodontology. So what is the treatment strategy, dear colleagues? First of all, please select the right patient. We never start with a surgery, at least not in burn. So what we do is, first of all, to perform non-surgical periodontal treatment. Make sure that we decrease the infection. The patients clean very well, full malplug scores 20%, 15%. Select the materials that are based on a sound biologic principle that I've shown you before. You can see the materials that we can recommend: autogenous bone, human allograft, human bone, some xenogenic grafts, membranes, of course, enzymatic proteins, and PDGF, platelet-derived growth factor. Of course, please use the appropriate flap design that should be selected and performed according to defect location with appropriate surgical instruments. In other words, please use a small blade in a small defect. Don't use big blades. Use magnification loops. And the final decision whether we are going to use a single or a combination approach is based on the defect configuration. In more complex defect, it seems that combining different materials like a graft and the biologic or a graft and a membrane could make sense. Okay, it's better than using only a fluid material, for example. Then, of course, the stringent postoperative infection control is very important in order to avoid complications. And these are the typical defects that we face. 3-wall defect. You see here I use one single material. If the defect is more complex, I go to combination for graft and the membrane. Let me show you our decision tree. Our decision tree is very simple. Of course, first we start with a non-surgical phase. We reevaluate after about 3 months. We may perform a second surgical phase in certain isolated cases or defects. And then when I go for the surgery, I select a small portion. I don't go for a very big flap. Smaller flaps can stabilize the defect better than larger flaps, okay? That's why it is very important. Open up the flap by using a papilla preservation approach. Characterize the defect. And if the defect is narrow and contained, or a 3-wall defect, I use only emtogain. If the defect is like a crater, but is contained, but very large, EMD and the graft. If I have a lack of bony walls, or maybe lack of 2 bony walls, I use a graft membrane. Maybe I combine the graft with a biologic. And then a perfect suturing technique in order to enable complete closure of the wound. Let me give you some examples, dear colleagues. 3-wall defect, simple case, straightforward. I use EMD. Please observe that at 1 year, I have very nice feel of the defect by re-entry. Then combinations. We like to use combinations of EMD and some grafting materials in large defects versus EMD. Why? Because sometimes it may yield to additional improvements. Not all the grafts, but if you combine it with xenogenic material, with DFTBA or with autogenous bone, the outcomes should be or appear to be better than combining this material with synthetic grafts like bioactive glass, like bone ceramic, etc. And this is what we found histologically. If you combine EMD with a graft with a bovine xenogenic material, what you can observe is the tooth surface. We have here newly formed cementum, periodontal ligament, and you can clearly see the integration of the graft and surrounding of the graft with a bone-like tissue. Clinical studies, comparative clinical studies, have shown higher improvements in complex defects when you combine EMD with a xenogenic material as compared to EMD alone. However, if you use this combination in the daily practice, how should you use it? Should you combine it first with blood or with EMD? Okay, don't forget that this is an important clinical question, and we looked at this question. So we pre-treated some groups. We took the particles of the graft. This is the NBM. We mix it with the Emdogain, with EMD. Okay. Then we took a second group, took NBM. Then we added EMD, and then we added blood at different time points. Okay. And we wanted to see what is going to happen with the proteins on the surface of these grafting materials. And what you can see here very clearly is, in fact, you see the particle of NBM of the xenogenic material with EMD. You see this very light staining. Okay? What does it mean? It means that if you have no blood contamination on the surface of the graft particles, you add EMD, and you don't have immediate contact with the blood, then the greatest majority or the greatest part of the biomaterial of the EMD will stick to the surface. Okay. However, if you don't wait enough and you combine EMD with the grafts and you add blood immediately, then what you see is the particle. And please observe these stain spots. The stain spots are very few, okay, indicating that something may happen. What does it happen? We have less molecules. That's why it is this fluorescent staining, okay, because we stain it with antibodies. So look at the absorption of EMD on the graft over time. What does it mean? What do these bars means? You take the graft, you add EMD and blood after half a minute, then you have maybe 20% of the EMD of the proteins on the surface of the particles. Okay, not so much. Then you do the same. You wait for 1 minute. You have almost 60%. If you wait for 2 minutes, you have maybe 80%. You wait 3 minutes, you have more. You wait 5 minutes, you have 100%. So in other words, dear colleagues, if you use the mixture of Emdogain and the graft, you should mix the two components at least 5 minutes before you place it in a defect, if you don't want to get significant loss of this protein concentration. Okay? And you see the same on the histologic slide. What does this dark brown line mean? It means that in fact the proteins, the enamel matrix proteins, enter the particles, the porosity, and that's why they are stained with antibodies brown. Okay? If you add blood immediately, then you have the counter staining with toluidine blue, indicating that is almost no protein penetration in the porosity. Okay, this is now demonstrated histologically, and you can see the same also on this scanning electron microscopic image. Look at the particle of the graft. Okay, this is here to the left upper corner. If you add EMD and you don't have blood contamination, then is this middle row. Look at the middle part at the high magnification. This is the precipitation of the enamel matrix proteins on the surface. Okay. However, if you have a blood contamination, and this is the the lower left corner, you have this part here. You magnify it, you have this middle slide. What can you see? Erythrocytes, okay? Because they are competing with the enamel matrix proteins, and these erythrocytes are sticking better to the bone graft. This is the nature, okay? So in other words, we have less cells there. What is going to happen if we don't have a contamination with blood. Look at the slide to the right, okay? At 5 days, you see the bar. PDL, if you have an EMD coating without blood, you see is very high concentration. If you have a contamination with blood, then it's less than the half amount of cells that migrate there, okay? In other words, if you have precipitation of DNA matrix proteins on the graft, you attract the cells, okay? And what are these cells doing? These cells are going to produce growth factors. We demonstrated that in another study, and these growth factors are contributing significantly to the healing process. Which are these growth factors? Epidermal growth factor, transforming growth factor, insulin-like growth factor, and you see some of them are produced 15, 16-fold more than without combination with EMD. And in fact, this is the biologic background for this concept. Okay, now I have demonstrated you the theory, but let me show you one clinical video on how we are dealing with this. So what I do in this particular case, you see here, this is a patient data preservation technique. I open the defect very, very gently. You see, I also use the tunneling instruments. You will see then these instruments also in my upcoming seminars. Very, very carefully raising the papilla. That's why it is very important to perform the non-surgical treatment before, in order not to have a heavy inflammation. Because if you have an inflamed tissue, it is much more difficult to cope and not to traumatize these tissues. Open up, in this case also palatally. Sometimes we don't need to open the defects at both sides. I like to clean the defect and the root surface using ultrasonic instruments and also using my curette. Okay? And now I characterize the defect. This is a so-called intrabony component. It is a non-contained defect. So one option is to use a combination of DNA matrix proteins and the graft. So what I did before is to mix the graft with EMD. And this was based on the studies that I've shown you before. So I mixed the graft with EMD. In the meantime, I place the sutures, okay, in the flap. In this time, I get the saturation of the bone particles, bone grafting particles with EMD. So what we use is a modification of the matrix suture. You can learn them from one of our hands-on courses. Then one layer of EMD on the root surface. Place the combination of the graft and the EMD in the defect. Do not overfill the defect. I don't want to inhibit the formation of a blood clot. The graft should be used as a kind of scaffold. This is a small trick. You can see also, you can harvest, in fact, the particles with your needle. They stick very well together. You take the particles and you apply the particle exactly in the defect very precisely. And close immediately the flap. Okay? And I do the same with the second defect. So first I treat one defect, close it, and then I do the second one, okay? You don't do a big salad, okay? It's very important. So in very, very small steps. This is the situation before the surgery, and look at the outcome after 2 years. Very stable, clinical situation. So another option that we can use is the combination for grafting material and the membrane, mainly a collagen membrane. If I use a natural bone mineral, cover it with a collagen membrane, we can obtain also periodontal regeneration. I've shown you that not every material and every grafting material is able to promote regeneration, but with a xenogenic bovine material, demineralized, deproteinized bovine bone, it is possible. And you can see here the formation of bone around the grafting particles. What is the added benefit of such a combination over open flap debridement? Okay, we screened the literature some years ago. We started with more than 2,700 publications. We ended up with 17 randomized controlled clinical studies that we also included in the analysis. And what you can see is that by using collagen membrane, maybe with a graft, combined with a graft, significantly improves the results. The gain of clinical attachment level is statistically and clinically higher with this approach than using a flap. And most importantly, also the residual pockets are significantly shallower. Okay, you can see the values, and please observe that we have here in the right lower corner this value 1.52 millimeters. What does it mean? If you use a graft and the collagen membrane, you get in an average 1.5 millimeters shallower sites, shallower pockets, compared to a situation where you don't use this combination. So in other words, these sites are easier to maintain. Okay, you have less niches for bacteria. So how do we perform this treatment approach? Look at this case, again a very challenging situation. And in this particular case, I performed the same surgical technique that you have seen before, using the same surgical instruments. But what I don't like to use, or I use very seldom, is a vertical releasing incision, especially in the area of the lower premolars. Okay, because in this area it can be very tricky, and if you would use a vertical incision, you may create a recession. That's why in the lower premolar area, what I do is, in fact, to extend my intrasulcular incision, open up first the buccal flap, and then I move on and may open also the lingual flap. Then it makes sense to use this template that I cut. The template should serve as a basis to cut the membrane. Because the collagen membrane is very hydrophilic, it may absorb the fluid very fast. Then I take my graft, I fill the defect, I remodel, recontour the lost bony walls, and then I place the membrane, the collagen barrier. Okay, usually what we use for periodontal regeneration is a native collagen. What does it mean? Native means that the collagen membrane is not cross-linked, because in the very moment you have a cross-linked collagen membrane, the membrane is much more stable, and we don't need a longer time stability than maybe 4 weeks or 6 weeks of perio regeneration. For bone regeneration is another story. For perio regeneration, 4 to 6 weeks. And then I take the other part of the membrane and I place it like a belt, okay, making or enhancing additionally the stability of the area. So then, of course, we close, as you have seen before. What we can do is also to use first a horizontal mattress suture, a cross suture. Usually I like to use 6-0 monofilm material. I do not pass through the membrane. I'm very careful not to touch with the tip of the needle the membrane. I close it, and then in this way, I first release the flap from the tension. Second point is that I stabilize the material. And then with the last suture, I simply and passively close the interdental papilla. Okay, so this is the approach that I use, and by using this surgical technique, you don't need to use pins. Okay, you don't have to pin the membrane to the wall. And as you can see it here, we always work with the instruments. I don't use the fingers. So this is the outcome after a couple of years in this particular case. There's another case where I looked at the situation and I used the same combination. And at the very end, you see here, after 10 years, we have a probing depth of about 4 millimeters. We started with about 10, and you can clearly see the outcome illustrated by the X-ray. So what do we do now, dear colleagues, in furcations? In this last part of my presentation, I would like to elaborate on this very important aspect. So what is the evidence for periodontal regeneration in furcation involved teeth? We looked again at the data from the literature, and we analyzed the entire published histological evidence based on human and also animal experiments. So the focus question was, which treatment modalities have been shown to result in formation of cementum, periodontal ligament, and bone in furcation defects as demonstrated in animal and human histological studies. And the second important question was whether complete regeneration in a class 2 and in a class 3 furcation defect may be possible. So on this complex slide, you see a compilation of our results. You see the animals and the human studies. In the first row, you can see the furcation closure in the furcation class 2. What we can say is that with different types of methods, GTR, EMD, grafts, combinations, biologics, whatsoever, we can regenerate a class 2 furcation both in animals and in humans, okay? Of course, the human studies are based on cases. You cannot make a high number of such biopsies. However, if we look now at class 3 furcations, we have very different outcomes. In animals, the furcation closure is possible in a class 3 with different approaches, mainly with a combination. Why? Because first of all, animals heal much better, and secondly, because these defects are usually created surgically, and obviously if you have a surgically created defect, it is not a naturally occurring disease, the healing potential is much better. Look at however, at some human biopsies. None of them demonstrated complete closure of a class 3 furcation, not even a partial closure. So please observe what you can conclude from this slide is that a furcation class 2 is a suitable candidate in some cases for a regenerative therapy. However, a class 3 not, is a contraindication. What is the best modality to regenerate class 2 furcation in humans? Is a combination. The best outcome was obtained with a combination of a biologic material like PDGF and an allograft. Okay? What about class 3 furcation, dear colleagues? This is a very important message. Don't try to regenerate a class 3 furcation. Most probably this will not be successful. I tried it myself a couple of times and it was not successful. I can show you some cases as well. Let me go now to the AP Consensus Conference, where they looked at the furcations. So what we look now is to categorize the defects. If you have a molar with a class 1 furcation, you don't need surgery at all. What you need is non-surgical treatment, plaque control, scaling and root planing. That's it. Class 2. If you have a class 2 furcation, please analyze very detailed the defect, especially the height of the interproximal bone, mesially and distally to the molar. Okay? If the bone level, mesial and distally, is located below the entrance of the furcation, don't go for a regenerative approach. Go rather for a resective surgery. If the interproximal bone level is located coronal to the entrance of the furcation and you have enough soft tissue to cover this area, in other words, you don't have a recession there, then I would go for a regenerative therapy, including mainly a combination approach. What about class 3 furcation? That means a through and through furcation. We never go for a regeneration. We go for a resective approach usually. And of course, you have a number of different approaches like apically positioned flap. We can perform the tunnel. We can have a root amputation hemisection. In some cases, especially if we have a vertical mobility of the molar, we may extract the tooth as well. Let me show you some example. Class 2 mandibular molar furcation. Very good indication because here we have a buccal involvement. I opened the flap, harvested some autogenous bone. Of course, the cleaning is very important. Fill the furcation with the autogenous bone, place the membrane, close the flap, and look at the outcome after 5 years. We converted, in fact, a class 2 into a class 1 furcation. Upper molar. You can see here 2 molars, number 6, number 7. The number 7 doesn't have an antagonist, has a caries, and is difficult to clean. So we extracted it. On the other hand, we focused on the first molar. If I have this intrabony component, mesially and the furcation involvement, I decided to go for a regenerative approach consisting of an autogenous bone and a collagen membrane. And if you look now at the situation after 5 years, what you can see here is an improvement of the intrabony component, but also an improvement of the furcation and a stability of the clinical situation. With this regenerative approach, I avoided tooth extraction and a sinus graft and an implant placement for this patient. So I improved the chewing function in this particular case. Please have a look at this particular situation. This is a young lady that was at that time she was 22 years old, diagnosed with aggressive periodontitis, and what we can obtain, what we can see here is that we need to save this molar. Okay, so what I did here is to open up the flap. Of course, first we perform the non-surgical treatment, then we reevaluate the case, and then I analyze the defect. Look at the complexity of the case, especially from a palatal point of view. We have an intrabony component, we have a class 2 furcation from mesially. Here we need a combination approach. So I use EMD, I use autogenous bone that I placed in a sandwich technique because I don't want to mix autogenous bone with EMD because it contains already blood, and stabilized additionally everything with a collagen membrane. And if I look at the case before the treatment and after 8 years, I think that everybody would agree that it is better. We don't need a statistic specialist for that. We can see that. Okay, you can see here a significant improvement, and this lady has a stability now, and we maintained all the teeth. What about some long-term outcomes? Look at here some 9-year results that we published many years ago. Deep intrabony defect at the beginning, and after 9 years, only 2 millimeters of probing depth. Please observe the situation, the baseline. 9 years later, regeneration of the intrabony component. Another case, before and after. And this is a 10-year study. In this study, I showed you already this case before. You can see a stable situation after 10 years. Even in cases where the tooth has an endodontic treatment, we can be successful. It is not a contraindication. Okay? The condition is that the endo treatment is performed by a specialist. But we can also be successful with a GTR. You can see this bridge after 10 years treated with a membrane. Very stable clinical situation. What about some long-term results in furcations? This is a study after 10-year follow-up. You can see that we can be successful in treating class 2 furcation defects. We can convert a class 2 into class 1 in the great majority of the cases. And these cases can be maintained stable up to 10 years in the great majority of the cases. You see 83% of the cases. And it doesn't matter what kind of membrane you use, non-resorbable or biresorbable. The most important is that you don't have postoperative complications and that the patient is well maintained over time. And this is our latest publication together with Professor Stavropoulos, where we analyzed the entire literature. You see, it was published now in January. And we looked at the literature, we evaluated long-term results, and we were able to include quite a high number of studies. You see more than 16 studies with a longer follow-up than 5 years. So, dear colleagues, sorry for this small break. What you can see here is the result of our analysis. So what we have found out is that, in fact, if you perform a regenerative surgery in an intrabony defect or in a class 2 furcation, then regenerative surgery is definitely better than an open flap debridement, okay, on a long-term basis. So you can improve the prognosis of your teeth more than 5 or 10 years, okay? And another important conclusion was the following, that the combination approach seems to be better than solo modalities. In other words, if you combine a graft and the biologic graft and EMD, or a graft and a membrane, you will be more successful and the site is more easy to be maintained compared to one single material, EMD alone, for example, okay? And let me come to my conclusions. So when we think nowadays about regenerative surgery, reconstructive periodontal surgery, the focus should be on periodontal ligament cells, because these are the key cells in periodontal regeneration, okay? They are responsible for periodontal regeneration, not the bone cells. Therefore, we need to understand the biology of periodontal wound healing much better, importance of the flap design. We have to be critical when we use a bone substitute. We prefer not to use them if not really necessary. And I would like to use certain biologics that promote periodontal ligament cell migration and proliferation, okay? This is important. In complex defects, in other words, defects where we have a lack of the bony walls, it is more difficult to stabilize the flap. I like to use nowadays also stable collagens, cross-linked collagens that may attract the blood clot, stabilize the flap, and would in fact also prevent flap collapse into the defect. Let me summarize the key factors responsible for periodontal regeneration. First of all, please control the infection. Never do a surgery in an infected area. Second, smoking. Control for smoking, very important. I know it is not easy. Some patients are very reluctant, but be aware that the outcomes in smokers is less predictable than in non-smokers. Defect anatomy. Okay, analyze very carefully during your surgical procedure the anatomy of the defect, and then choose one or a combination of materials. If your tooth is mobile, please stabilize, splint your teeth, because it's like a fracture. If you break your arm, usually you're getting a stabilization. You don't run on the street with a broken arm. So that's what you have to do with your teeth. Stabilize. Flap design. Please make sure that your papilla is not damaged and that you can close the interdental area. That's the whole story behind. Prevent infection, stabilize the blood clot. Be careful and very selective when you choose your regenerative material. And again, I repeat, focus on periodontal ligament cells and not on the bone. And then the next point, and this is the lifelong maintenance, because without a thorough lifelong maintenance, you will not be successful. It's as simple as that. And I can show you one very nice example. This classical study by the group of Axelson and Linde. You see the follow-up of 30 years. And these patients were diagnosed with a severe periodontitis. What type of treatment they have received? It was non-surgical and surgical periodontal therapy. And this treatment reduced the pockets. The patients were enrolled in maintenance, very thorough maintenance done by dental hygienists. And then if you look at the outcomes, and for the main reason or main cause for tooth loss, what was the main cause for tooth loss? It was not any longer periodontitis, but it was root fracture, it was root caries, and perio reasons were numbers 3 or 4. Okay? So in other words, if you are able to maintain and to stabilize the clinical situation, then we can maintain the teeth even lifelong. These patients were quite old. Some of them were older than 90 years at the 30-year evaluation period. So, dear colleagues, keep this in mind. And I hope that with my lecture today, I was able to give you some insight in this complex topic. Of course, I could talk for hours and for days. And of course, the hands-on exercises are very important. If you want to learn the techniques, then we have, of course, to perform also a hands-on course. And you can also attend one of our live surgical courses that practically illustrates how we can cope with difficult clinical situations. Thank you very much, and enjoy your evening. See you next time. Bye-bye. I will answer some questions. I don't know how I can get them. Maybe I get them via my mobile. Okay. So wait a little bit. What is MBA? MBA is a xenogenic material, is a natural bone, bovine bone. There are different materials. In many studies, they use bios. They can also use some other materials. In the majority of the studies, it was bios or bios collagen. Yeah. Another question is the bloodless. Only if you use Emdogain, okay? Otherwise, it's not important. So if you would use Emdogain and you combine Emdogain with a graft, then make sure that when you mix Emdogain and the graft, you don't have blood, okay? That's important. So because the blood has a higher affinity to the graft than Emdogain, okay? So if you would mix them in the same time, then you have a mixture with the blood and the graft, and you have less enamel-matrix proteins on the graft. This is the philosophy behind, okay? And the same go through for the root surface. When you apply Emdogain on the root surface, make sure that you have conditioned the root surface, you have dried it, and in the very moment when you apply Emdogain on the root surface, you should not have blood. And you always apply it from apically, moving slowly coronally. Then you have this conditioning and biologic transformation of the root surface, and then you can immediately close the flap. It depends what kind of technique you use. Another questions, Juliana? I cannot hear anything. You have some other questions? If you would have some other questions, you can write me an email. Not too many emails. I don't like to answer them, but you can send me some, or you can send to the organizers, and they can provide me the um, the question, and then I can answer you these questions also next time. No problem. Okay, so I hope that two questions, two more questions. Wait a little bit. That's the one question is relates to the flap. If you have the possibility to open it only from one side, depending on the configuration of the defect, try to do it. I very well know that it is not always possible, but I think that in 70-80% of the cases you can do it from one side, and then it means that you can much better control the stability of your flap. And if you have magnifying loops and a good visibility, I don't think it's a problem to clean. Obviously, if you have a single flap approach, you will not be able to use a membrane. But as a basic idea, if possible, try to open only one side, because in this way you additionally improve your outcomes. If the tooth is dead, of course, never, I mean, if you have a non-vital tooth and you are sure that the tooth is non-vital, first step is to perform a proper endodontic treatment and wait. Sometimes it may happen that the tooth is vital, but the defect is so deep that during the surgery you go until the apex. So in such a case, I would recommend that you do immediately, maybe even during the surgery, an endo treatment. You place some medication, and then the specialist is going to finish up the endo treatment, or immediately after. But don't wait too long, because I had cases at the beginning I didn't do that. So I was waiting, and during the healing, the tooth became non-vital, and then the outcome is going to deteriorate. So, okay, this is very important. Always first the endo, because the pulp or the root canal may serve as a reservoir for bacteria. So we have to treat that area, close it, and then you go over to the perio treatment. Okay, I think I at least I hope I was able to give you the right answer. Any more questions? No more questions? Okay. I wait for the message. Thank you. Okay, so I hope that you didn't fall. You are not falling asleep, and you could learn something. And let us meet next time, and we'll start with some soft tissue surgery. So I wish you again a good evening and a good night, and see you next time. Bye bye.